Moving right along, we have our next panel coming up, how to make sure your healthcare facility is fully prepared for downtime, where the experts will discuss how healthcare providers can be prepared to support maximally safe and efficient clinical processes when their IT systems go down or are under maintenance. Please join me in welcoming the session's moderator, Charles Wayne Hale, president and founder of Hale Consulting Solutions, LLC, and our esteemed panelists, David Rauschendorfer, CEO of Cybersecurity Resource, and Carley Applegate, founder of EvelynElaine. Warm round of applause for them.
All right, good morning, everyone. Made it to day 3, the few, the proud, the survivors. I appreciate seeing you out there. The sober. We're not betting on that. Before we get started, I wanted to give acknowledgement to our MC, Melissa. She's been doing a fantastic job this whole time and filling in the gaps as she just did. I applaud you. Thank you so much. So the title of this particular panel is how to make sure your facility is fully prepared for downtime. So this is something that's near and dear to my heart as a technology professional and as a cybersecurity specialist. We've seen throughout all 3 days how much technology has become ingrained into our healthcare system. Just about everything we do involves a computer or a mobile device or some type of device. So what do you do when it's not available? How do you prepare for that? So we'll start off with some introductions. As she said, my name is Charles Hale. I'm the president and founder of Hale Consulting Solutions, LLC, and we are a boutique cybersecurity firm focused on the healthcare industry. And really our mission is to reach out and help healthcare providers, healthcare organizations do what they do best, provide healthcare. So we can help them not have to worry so much about cybersecurity and access and all of the other things that are really ancillary to what your job should and what you want it to be. David, you want to go ahead and introduce yourself?
Yeah, definitely, thank you. So my name is David Rauschendorfer. I'm the founder and CEO of Cybersecurity Resource, and much like Charles, we specialize in the healthcare sector, doing a lot of the HIPAA security risk analysis for organizations. And then our main mission today is to focus on those small and mid-sized organizations that are actually providing services and solutions to healthcare providers as well. So ensuring that when they bring solutions to the market and to your organizations, that they're actually secure upfront. So that's kind of our main focus, providing greater access to cybersecurity solutions and assessment services across the healthcare industry.
Thank you, David. And Carley?
Carley Applegate. I am a recovering nursing home LTAC and home health and hospice administrator. And I'm the founder of EvelynElaine, and it's the first standardized training for non-professional caregivers. We train clinically based modalities for those family members who are in that caregiving space, never intended to be. So I'm excited to be here.
Thank you. Thank you very much. Well, let's get things started off here. David, let's talk a little bit about downtime. When we hear the word downtime, we think something's gone wrong, that something's broken. But there's also, planned and unplanned downtime. Can you talk a little bit about the difference, and is there good downtime?
Yeah, definitely. So, many people in organizations don't always realize that there's planned downtime because it's usually done outside of kind of standard business hours. But it's pretty common for organizations to go through that, to just get through their patching that may need to be done, updating infrastructure, and things of that nature. So it's very common to have kind of that planned downtime and that your kind of IT teams are managing for you in most cases. The unplanned downtime can be things where it's kind of a denial of service. You're in there trying to do your job, trying to work through your operations, and you all of a sudden can't do what you're supposed to be doing. That's when it gets a little scary, right? And so those unplanned downtimes become, a lot more catastrophic at times, and there's different levels of that, but usually, they can be managed and mitigated and be able to kind of make sure that you can continue operations, and that's kind of a part of what we're talking about here. So when you do have unplanned downtime, you can still continue those operations, provide services and care to your patients, and kind of maintain your daily workflows. So that's kind of what we want to help organizations focus on in this panel, is making sure that you're able to maintain those operations in any of the kind of scary downtime procedures.
And Carley, from your perspective, from more of a business and healthcare provider perspective, what does downtime mean to you? How does it impact the work that you guys do?
I actually love downtime. Honestly, I know that sounds weird, but it really, I think downtime is a great time to really measure your clinicians and see, are they clinical? Are they doing assessments? Are they clicking buttons, right? You can really sift the wheat pretty quickly during downtime. And so I love it. It's always work on the back end, especially if it's, not planned. But I think it gives everybody an opportunity to stop clicking buttons and actually, practice hands-on care, which, gosh, we've gotten so far away from it. I think the panel discussed it earlier, all you're doing is treating the EMR and not the patient. And so I love it. But it does interrupt business, so you always have to have kind of a coup afterwards. Like, how are you going to get whatever data back into the system? And who's going to do that too? And that's kind of, that's always been a challenge too, because it is disruptive. So in my current organization and then other organizations that we've always, had some type of coup to, kind of assign, who's gonna put the stuff in the medical record, who's going to send the reports, who's going to clean everything up. But like I said, you really get to see who are your hands-on clinicians, whether that's nurses or therapy or even your aides, just the whole gamut of things. You really get to see who's actually doing the care, so I love it.
That's a great answer. Yeah, how it goes, smooth seas don't make for skilled sailors, something like that.
Yeah, absolutely,
right.
yeah.
Yeah. And just to add to it, more and more we're getting into this integrated age. There's solutions for every part of the business, and we're leveraging and leaning on those solutions very heavily. And so, not all of those are in-house. A lot of times we're using third parties for those, and there's a lot of breaches and data loss where it has something to do with a vendor's solutions going down, not always internally. And being able to have downtime procedures, figuring out how you're going to continue operations, and then also how you're going to bring that back up to speed when you get that solution operating again, inputting the data back in there so you have that continuity to maintain business, long term is always key. And so it's, we're becoming an integrated state where it's crucial that we kind of have these plans to know not only what we're going to do when it happens, but how we're going to bring it back after the fact.
And I think you have to test the plan. Whether it's just part of an IT plan or a disaster plan, because, I love my nurses. I love you guys. I really do. But the printer breaks down and it's like World War III is happening. And so, you have to train them. They have to be prepared for when this happens. And it can't just be in a manual somewhere, because that's when panic really starts to set in. The internet's down for 30 minutes, people are freaking out, the printer's not printing, the poor printer is sacrificed, so having a plan for these things is huge, and testing it on a regular basis.
Well, and that's an interesting point you make, that you love downtime as long as you have a plan. So what are some of your top considerations when considering and planning for downtime?
Well, first and foremost, it just goes down to the basics, right? Are you doing rounds on your humans? If you're in a facility, do you have notebooks and pens available so vitals can be written down? Do you have a format in which the nurses need to remember how to document their notes if we're doing it on paper so we can easily move it back over to the computer? How are you actually going to communicate if you don't have IM? Are you going to actually have to go to the next floor and interact with a human being? And then in the home health space, granted, it is a little bit easier because we don't have as many integrations like you were talking about. We have web-based vendors, so if the internet's down. But again, can you document without the computer? Do you have that skill set anymore? Or have you lost it? And so, again, we train on downtime, at least once a year. But living in middle of nowhere, Wyoming, it happens on a regular basis just because, we either lose the internet or storm or, some type of data disruption. And like I said, it really just does help thin out the herd and who's able to adapt quickly.
And I think that brings up a really good point, right? Many organizations are really good at testing their downtime procedures from an IT perspective, how to bring data back. But it's really at the operational level that, many organizations struggle. What do we do in that downtime? How do we maintain those operational workflows to continue servicing and serving patients and doing all of that? Mm-hmm. And it's often never tested at that kind of departmental level or kind of operational workflow level. And that's, oftentimes either overlooked or not considered as a requirement. And so, when it does happen, that's when organizations really start to struggle and scramble and try and kind of maintain,
And we focus a lot on the clinical end, but, we all know that there are so many people in any facility. You've got housekeeping and laundry and dietary, and again, are they able to operate without, pulling up those menus? Are they able to operate without, logging in those loads of laundry? So again, we focus on the clinical so much, but we all know that there are, for every nurse, there's 10 or 15 people who aren't clinical making that clinical operation happen. So, don't exclude your ancillary teams by any means when you're testing these plans.
Well, and you're talking a little bit about testing the plans, and of course that's very, very important, but how do you go about testing a plan other than just going down and flipping off the power switch?
I've done that.
You've done that?
Yeah, from plan testing, a lot of times what I notice in organizations is there's a disaster recovery testing, right? And so that's kind of back to, we have backups and how are we going to retain that data and put it back into the system. But for the instances where it's oh no, everything is down in the middle of the day, that's really something's wrong, there's a security incident or something of that nature. And most organizations don't really look at kind of an incident response plan and what are the most common incidents that happen in the healthcare sector. And for those type of security incidences or breaches, how are we going to react as an organization to those? And that's where it really gets into a team across the different levels of the organization, from management, departments, or clinical staff, to be able to have the right steps and test and then know what they're going to do in those scenarios.
Well, and I'm thinking as we're going through this, there's different types of downtime, different levels of downtime, from the printer is out of ink, what do we do, to we've been hit with a ransomware attack and it's going to take us 6 weeks to restore our systems. Yeah. Kind of talk a little bit about how you prepare and address based upon the scale of the downtime.
Yeah, so there's definitely different levels of backups, right? So there's kind of your standard backup where you're going to want to have your RTO, RPO, like recovery point objective and time objective, how long it's going to take to recover, what's okay for the business, and what point in time are we going to be able to back up to from when that data was input, all the way to kind of your resiliency. So how are we going to do business continuity? How are we going to maintain operations? And that may be a little bit different, right, from moving to manual paper processes, or being, it depends on those operational workflows at that department level, what they need to do to kind of maintain business, where it can be, a extended period of time for a ransomware attack, to be able to get systems back up and all of that data working as operational as possible. So there's definitely different levels of that, and I usually attest that to, again, kind of an incident response plan, where it's going to go through a lot of that, and then you'll talk about all of those things, both disaster recovery as well as kind of business continuity.
Carley, we talked a little bit about communication and the need to have backup communication, things like that. But there's different communication stakeholders. You, of course, have your staff, your ancillary staff, but then there's the patients, there's the media, there's all these other things. How far do you need to go with this when you're planning for downtime, as far as how extensive is your communication plan?
Well, I think that you almost have to have a tiered plan, right? You're not going to alert the media when the printer's out, right? You're not going to be calling the governor. You're not going to be calling emergency management for the county that you live in. So you have to have you have to have an appropriate tiered response for the length of time you think you're going to be out. The first is the staff. Right? You've got to start with the staff. Either you send your managers out with one defined statement. This is what's happened. This is what's going on. Then have your staff start communicating with the patients and just building a really solid tree. But it's that defined statement, I think, that sometimes gets lost. Right? Like we're only going to say this at this time, right? And then, again, it really depends on what your tiered plan is, Are you looking at 72 hours? Are you looking at a couple hours? Are you looking at, like you said, 6 weeks? Anything greater than 24 hours, definitely local vendors, start reaching out to your local vendors, probably emergency management just in your local county, and then work your way up the tier. But it really does start with the staff. Again, that they know what's going on. They don't have to think about what's going on, and then the message doesn't get lost. And if you can get that down, that's going to cover probably about 80% of your miscommunications, right? And that's something that's really easy to test. It's almost like the telephone game. Send out a message to everybody and see what the end message was, and start practicing that with your staff. It also depends on the size of your facility, too. I know that there's some people here from enormous hospitals, and then there's some here from small, critical access hospitals with 25 beds. Those smaller communities, the newspaper's going to know what's happening long before you do. So you need to have it scaled appropriately to your size.
Cool. And I would encourage you also to consider your fellow healthcare providers in your communication plan, because we've seen instances just recently of hospitals. A large hospital on the East Coast got hit with a denial of service attack. They weren't able to serve the patients, so they sent them to another hospital without telling the other hospital they were sending them their patients. So you got to consider that as part of, they had a backup plan. We will send our critical patients somewhere else, but they hadn't thought it out completely. On the topic of communication, the content of your communication, as we've seen fairly recently, is very important too. Exactly, that everybody's saying the same thing and that they know what to say, because there are certain key terms, we will use breach as an example, that have legal ramifications. David, you talk a little bit about the carefully crafting your message when communicating downtime?
Yeah, definitely. So I feel like we're getting better and better about our communication strategy and plan in the healthcare sector. I think many organizations realize that you need to have one, especially as you see other healthcare organizations go through breaches or incidents, and having that tiered structure like you're talking about for different levels, so that you don't immediately take a downtime incident and start communicating out to the newspapers that, hey, we had a breach, and you haven't had the time to even do any type of root cause analysis or understand if you had any actual data loss in that incident or anything like that. So, I think the larger organizations definitely have teams to manage that. They go through their legal counsel, so nothing comes out of the organization before it is reviewed and looked through by management, gone through by the legal team, and then communicated out. But at smaller organizations, you're not going to have that depth and that bench to leverage. And so I think it's just a point of actually having a communication plan, something that's documented. For this level of incident, we need to make sure we're communicating to all of our internal staff. We're going to go through, see what happened, do root cause analysis, identify if an actual breach occurred. If so, we're going to formulate this type of message. It's going to go through these people for checks and balances before we ever communicate that out to the public, so that we're all on the standard message. It's all kind of streamlined, and we just don't have, nurses out saying, hey, we had this big data breach, and posting that on Facebook and letting that kind of go viral, right? And so you don't want those things to happen. You want to have a controlled message that you can kind of put out there, because you don't want somebody saying, oh, we had a breach, and then it's like, well, how big a breach did you have? Did you lose everything? Was it, 5 patients, 1 million patients? How many records were lost or affected in this kind of incident? And so having those checks and balances, having a standard plan in place, and being able to walk through that kind of, so again, in a kind of incident response testing, saying, well, if this incident kind of happened, what are our timelines to identify what actually happened there, to do our root cause analysis, and then what are the steps and who needs to be involved in that team to have that communication strategy out to the public.
Thank you. And on the topic of breach, and bring that one up because there's specific legal requirements about once you've identified there's a breach, you've got, I think it's 48 hours to notify the people that their data's been lost. So saying that it's happened before you know whether it's really happened or not can be really impactful to your organization. Let's see, let's talk a little bit about, well, Carley, you talked about recoup and the importance of getting back together after you have a downtime. So this can actually be very challenging in an organization, is actually resuming services after a downtime, especially an unplanned downtime. So can you talk a little bit more about the recoup and how you guys start doing business as usual again after recovering from a downtime?
Well, again, your recoup plan is different than, it's different based on how much time that, has been lost and what areas that are affected. I think it comes down to your actual, your policies, right? We tend to make these really good, long, super complicated policies. And so, after downtime, or any type of data, not quite a breach situation, if you have these, really complicated policies, then that's what your oversight is going to look for, right? So I think it's really important to, before you even create a plan, to go back through your policies, and are they as clean, are they as neat, and are they as simple as possible while still holding the regulation? For example, at post-acute care, there's no regulation that says that the data has to be documented in the EMR, right, during downtime. It just has to be documented, right? Time, signatures, all of the things. So if your policy says that you guys are going to implement it in the EMR, you've just created so much more work for yourself, right? Versus just taking the paper, the couple hours of paper documentation and scanning those into the chart. If you're going to do a root cause analysis for all of the departments, your root cause analysis for all of the departments should not be the same for IT as it is for maybe your med surg staff, right? Like, because there's different levels of understanding, and there's different levels of approach too. And I've walked into facilities where it's a one size fits all, everybody's gonna do the same thing, and that just doesn't make any sense, because you're going to have, again, departments that won't need to recoup. They might have to reboot, they might have to update drivers, they might have to work with IT on passwords, but they don't need to recoup. And so I really think that that's where it starts, is making sure that, again, any area that needs to follow a process, that one is tailored to that department, that expertise, and it is as simple as possible, because you want to limit that recoupment time so you can just get back to business. Business is already hard enough as it is. But if you create highly complex recoup plans, then it may look glorious on paper. You may get an A+ from Joint, but you're going to have to follow that at the end of the day. And so, when you go to actually implement one, if you have to implement one, God forbid, it's just really important to try to keep it as simple as possible. And again, I think we get away from that sometimes.
I think you made a really good point about the policies and the documentation. I've seen that a lot when working with several organizations, especially small, mid-sized organizations. Policies are seen a lot of times as a check in the box. So they'll have a policy set, but it doesn't really do anything for them per se, right? And so I've done a lot of kind of training and consulting where we'll develop a high-level set of policies to meet all of the regulatory requirements. But the point is to define and document procedures at the department level so it makes sense for each department within their operational workflows. So we drive security through those operational workflows while kind of documenting the solutions they're using, the backup procedures they will utilize if needed with those solutions, and how they'll maintain business in the event of a disaster. And that really gets specific down to the individual departments. And you'll be surprised that not only the type of efficiencies you can find in going through that exercise, but in large health systems, you'll find that they're using very similar solutions across many departments that maybe they can centralize and do a lot of cost savings and things of that nature as well. But it really can streamline your operations, and that's something I always enjoy, being able to integrate both the cybersecurity aspect and the business operations aspect and make it make sense for the business to take on those activities. And then, you highlight a lot of things in going through that as well.
No, and something I drew out of that I think is an important point to make, you mentioned, is, compliance. HIPAA says you have to have policies and procedures. Are they useful policies and procedures? Are you going to be able to implement them? Will they really help you? And that's the division between, are you compliant or are you secure? Are you prepared?
Right.
So I think that's a great call out as part of that illustration. So we talked a little bit earlier about downtime and planned downtime. Now we operate in a global world now. So what are some of the challenges around downtime and when you've got maybe your CRM is operating on the other side of the world in completely different time zones?
It's always interesting, again, when you're working with a lot of vendor solutions, I've worked with integration teams as they bring on these solutions. A lot of time that isn't even a conversation. How is this going to be managed if that solution goes down? who's going to be responsible and at what level of kind of role and responsibilities does the healthcare facility have compared to the vendor, and what is the vendor agreeing to in that process as well. So most vendors are really good about planned downtime, making sure that it doesn't affect any of the kind of client operations at the healthcare facility. And they'll usually work with the IT teams if something comes up, and kind of work through that. But when it's not planned and it does go down, that's when a lot of times people are kind of scrambling. And if you don't have a plan in place that says this is how we're going to maintain operations without this solution, and then this is how we're going to bring it back so that we can get back to full business as usual, it's a struggle for many departments, right? And sometimes they're just like, well, I guess we're done for the day, and we'll just kind of go home and wait for IT to figure it out. So having those procedures at that departmental level that kind of walk through those operational workflows so everybody is aware, testing them so that the management at that department knows this is what we're going to do, this is how we're going to maintain. It becomes a lot less stressful, ease of use throughout all of those operations, and just kind of provides a peace of mind, really. So I think it's pretty effective when you're able to kind of go through all those necessary steps.
And I always, when I'm looking for a new vendor, especially for like EMRs, do they have an offline option? Somebody was dogging Meditech yesterday, but man, no one broke into Meditech because there was always that offline option, right? Looking at those vendors, do they have an offline option? What are their backdoors, right? Does your central supply have a relationship with your Medline rep where they can call in and say, hey, we're down, I can't order, but this is what I need? Again, like it's the shifting of the wheat. You really get to see who shines in these areas. So many vendors, they have those options, just no one asks about them. They may be relics from the 90s, but they're like, yeah, we still got it up and running. It's, 4 people are using it across the globe, but yeah, we've got it if you need it. And I think that's, we tend to get away from that, like when we're looking at vendor negotiations and development and stuff like that, like what is your basic option available? What is your backup? What is your offline version? Can we fax payroll? Is it going to be smoke signals? Is it going to be carrier pigeon? Whatever. But most vendors have it. We just don't ask about it. Especially, in the more management, we kind of assume somebody has asked those questions already for us, and that's almost a derelict of management, I think, overall, is not knowing your vendor's processes.
It's easy to leverage, like when you're doing vendor security assessments and you want to make sure that they have a secure solution for the data you're going to be sharing with them. A lot of times that's just on IT or the security team to go through those processes, and management or that department manager that's going to be using the solution may not even be on that phone call. And so they may not have any idea of what that would look like. And it's not really something that they're thinking about, right? They're thinking about, oh man, I got this shiny new toy that I get to go, use and utilize, and it's going to make my life easier. Not so much about, well, what happens after I'm using it and it no longer works, right? And so, I think it's definitely important to have everybody involved to kind of walk through all of those steps, because vendors do have that, right? It's a requirement. Everybody's asking them what it is, but it's not that it's communicated or documented in many cases, and so people are just unaware of what that process is going to look like when it does occur.
Well, because it's not the shiny new product that they're trying to sell, but they still have it on the back shelf somewhere.
Yeah.
But I think that's, like you're saying, the managers have to. They got the shiny new toy, but you need to know if you've still got that backup in place.
Well, and I would encourage people on top of that, that a lot of us go through that process when we're contracting for a new product, but then it's just on auto renewal. And it may be 5, 10, 20, 25, 30 years before anybody takes a look at it again. So, include that when you're going back through your reassessments too, is go back and say, okay, they had a product that worked fine 5 years ago. What's the options now? How is it looking now? And that's not just for disaster recovery, but for security in general. I see we've got about 15 minutes left. Does anyone in the audience I would invite people from the audience to come up, any questions they have about the process or disaster recovery, backups, business remediation? No?
No questions?
Oh, take back that sober comment. All right. Well, let's see. We've got some time. Is there anything else top of mind that you guys would like to talk about? Anything we may have missed?
Well, I think downtime is also a good opportunity to review who has access to what, too, and then have that part of your coop, because there's a lot of people who think that they need a lot of access. And sometimes it's absolutely legitimate, and sometimes I think we just get, it's what some other manager allowed, so we allow it, and we keep on going. Like, does every clinician need a work email, right? Does every, dietary need access to a database? Like, I think that at times, again, we just kind of allow some old ghosts to just kind of roam the halls and facilities especially, and we don't cleanse we don't cleanse the palate, and we don't say, okay, we're reviewing the standard of who has access to outside email versus internal email versus no email at all. Like, are we reviewing who actually, who needs a computer? Like, we all think we need it, but I'm not that old. And when I started in healthcare 20 years ago, there was one computer on the med-surg floor, one. And that was to put in labs and orders, right? And to admit somebody. Everybody else didn't have it, and so it wasn't that long ago. And now we're to the point where, I walk through my local hospital and, volunteers are like, oh, here's my business card, you can email me. And I'm like, why? Why do you have that? Why? And so I think that, again, having part of your coop at least is just to review who has what. And you could probably go on for hours about who has what, because you actually have to deal with it.
Yeah, there's definitely a lot of times, and again, we run into it all the time, where it's like a new manager takes over a department and they just continue on with what has been done. And then, other times where people come in and they're like, well, you don't really even need access to the EMR, like you're not doing anything there. Why do we need to grant you that access? And so, it's just a part of kind of the risk exposure that you're allowing to have that happen, right? And I think from a kind of disaster recovery and being able to manage that, it's not a sexy answer that anybody really wants to hear. A lot of it is documenting and testing, and nobody wants to go through those documenting procedures, right? It's not always the funnest. But again, you'll be surprised on the benefits that come out of it when you really do, because it highlights a lot of things. I've done it with many departments where the management was like, I didn't even know we were doing that, or I didn't even know we were using this solution. Or they're like, we're paying for this software and we haven't used it in 5 years. Or, there's a lot that comes out of just kind of documenting those operational workflows, to the point of understanding how you're going to recoup and manage any, disasters that will happen, or, denial of service or lapse in having access to that data or solution that you're leveraging every day.
Yeah, that's a very good point in having all levels of staff involved in those evaluations, because yeah, that makes perfect sense to me as the president, but I really don't know what she does. So.
Yeah, and once you go through the exercise once, it's way easier to maintain, right? It's just getting through that first exercise that's a little bit of a hurdle if you have nothing documented today. But again, you'll be surprised at all of the benefits that you'll reap from that, really.
And turnover too. Having a plan to train the turnover, especially managers, just because when something does hit the fan, the employees are going to look to that manager for leadership. And if they haven't done a drill or at least a tabletop, or you're really setting up your managers for a potential failure just by not setting aside or scheduling that time to say, to do like either a mini drill or a tabletop, and not something on health streams, not something on Silverchair, but an actual review of the plan, because if it does happen, you're going to have a lot of trust loss between your managers, your new managers, and those employees that they supervise, because a lot of employees think we learn this stuff through osmosis. A lot of managers think that people learn things through osmosis as well, and we all know that's not the case. But, when you have those key turnovers, you should plan on having a drill, really.
I think that's a great point, because in reality, from the end user's perspective or from the management perspective, when I walk through those, that's really the benefit that they see right up front, is in the event of turnover, not only just management, which is key, but other key resources in the departments. I think if you have a documented plan, this is kind of our daily operational workflows, these are the solutions we use and what we're responsible for. If you can hand that to somebody to go over and kind of review, they'll learn so much from that information just walking into it. Not only you won't lose that continuity between management and that turnover, but they'll be able to get up to speed way faster than just trying to follow somebody around all day seeing what they're doing, right? And so having that is key for that turnover, especially at the management level. Yeah.
And the more simple it is,
right,
the easier it will be to navigate too.
Definitely at those procedure levels, making sure that a fifth grader can understand it is key, so that it's easy to pick up, be like, oh, I get this, I understand what we're doing, I've heard of these solutions, and there's always some time to get comfortable within any new workflows as turnover happens, but having something documented, this is how we manage it here, this is the expectation as well, is vital to kind of maintaining those operations through that turnover.
And something you brought up that triggered previous experience and stuff, maintaining documentation, we all agree that it's important, we all think it should be due, nobody wants to do it. How do you go about assigning a responsibility? How do you, at what level do you say, this is who is responsible for making sure that we have accurate and complete documentation of our workflows and our recovery procedures?
So when I worked with different health systems, I usually put it on the security team. And so what we do is we walk through kind of a process mapping, kind of a RACI chart that says, here's all of our policies, all of our security controls that we have implemented across the organization, and who's responsible for those controls. So when you really get down to the departmental procedures, it's not that they're responsible for everything that IT does, that everybody does. It's really focused on what they're doing in their day-to-day operations. And so you can get more people involved and get to that level. But I tend to put it on somebody on the security team to walk through initially saying, here's what we're saying you're responsible for. The management is involved when that process happens so that they have input to say, no, I don't think I'm responsible. I'm not doing access control for this or whatever it may be. And so they can help define that level of responsibility for their department. and then being able to say, okay, well now you've agreed that you are responsible for these controls or security practices across your operations. So let's document now what you're doing to manage those controls. And so again, a lot of time it's the security team, but it's really the management at all levels that are walking through that to then say, what does this mean to me? What is my role and my responsibility in security? Because everybody at every level across the organization has a role in security, but we're not very good at defining what that role is a lot of times. And so I think it's important to make people understand that they do play a role, they do have a level of responsibility, and what that actually is. Not just saying, in your annual training, like you are responsible for making sure that, you're not handing out patient data, and that there is a deeper level of kind of responsibility for security and where they fall in there.
And if you're wondering why this falls on security, our 3 tenets for security are confidentiality, integrity, and availability. We have a running joke that the only true way to secure a system is to disconnect it from the network and turn it off. But that violates the very principle of availability. So that's kind of why it often falls on your security team or your chief information security officer to make sure that we've got a plan to how to address making sure systems are available.
Definitely.
All right, still no questions. I think we can adjourn a little bit early and let people have some time back.
Yeah.
Thank you all very much, and hope everyone's having a wonderful conference. And thank you guys for the engaging conversation.
Thank you.
Thanks so much.
Round of applause. Thank you so much, guys.